position, but if you remember in rheumatoid arthritis, there was HLE DR4 and DRB1. Here there is HLE B27 gene responsible for this disease. HLE B27 gene, same risk factors: smoking, viral infection, Epstein, rubella, mycoplasma, stress, cold, trauma, history. This is main factors. And when these trigger factors calculate, start some immune changes like T cells activate, interleukins activate, TNF-alpha, macrophages, and targetedly they start damage some specific place. In ankylosing spondylitis, target place spinal column, but before spinal column, they affect enthesis. What is enthesis, students? Enthesis is soft tissue part of connection of tendon ligamentum apparatus with bone. For example, it's ligaments, here bone, for example, and this part called enthesis. And clinical manifestation and complaints of which mean inflame of this disease mainly start from enthesis, because pathophysiologically inflamed cells first affect enthesis, and due to inflame of enthesis, patient feel joint pain, inflame of joints, but first, as I said, it's not joints. First, it's enthesis. But in common, how you can understand patient that it's joints or enthesis? They just think it's joints. Enthesis will be affected. Enthesitis, it's called. Later, inflamed cells start damage bone structures. And mainly, they will be same situation like in rheumatoid arthritis. They start inflame of cartilage tissue, but target place here spinal column. If in rheumatoid arthritis, target place was small joints, hands, feet, here spinal column. Intervertebral part become to inflame. For example, if here one vertebra, second vertebra, third vertebra, etc., they will be inflame of the cartilage part. When they will be inflamed and overgrowths, what happened? Decrease cavity as usual. Later, this cavity will be lost, and it's called ankylosis. If you remember, in rheumatoid arthritis, I also said about this condition, ankylosis, when no cavity between joints. And can you imagine what happened with patient with ankylosing spondylitis? Big part of the spinal column become to ankylosis, and absolutely he will be immobile, because ankylosing spondylitis affect all spinal column. Start from the lumbar, but later thoracal, later cervical, but mainly sometimes start from lumbar. Except this, ankylosis happen not only due to cartilage overgrowing and inflamed. There will be also other pathophysiological process. There will be overactivation of osteoblast, not osteoclast, osteoblast. Due to that, there will be damage some part of the bones due to inflamed process. Osteoblast start growth new bone cells here. They mainly grow vertically here like this. That's why it will be also help for what? Ankylosis. Students, understand me? Or not?
No.
No? Okay.
ما جزيرة.
Okay. Why ankylosing spondylitis mean ankylosis? Ankylosis, no cavity between joints. Yeah. This
Yes,
understand this?
ma'am. Yes,
Yes.
ma'am.
Spondyles, it's soft tissue between vertebrae. They will be inflamed of spondyles. I already showed. Look here. Mainly ankylosing spondylitis affect spinal column, as I said. Yeah. Mainly, there will be also other part of the joints. Soft tissue, cartilage. Here also, there will be also meniscs between. 1 second. Meniscs between vertebra. Yeah. For amortization. And when they will be activate immune complex, antigen, antibody complex, inflamed cells, inflamed macrophage TNF, interleukins T cells, as usual for autoantibody, for autoimmune disease, they affect some target place. For rheumatoid arthritis, its target place is synovial membrane of first small joints. For ankylosing spondylitis, target place it's spinal column, between vertebra, target place. They affect this part, and there will be growths of cartilage. Except this inflame of the menisc, because spondyles, it's menisc, soft tissue, soft part of spinal column. But in same time, there will be an activation of osteoblast. Do you remember in rheumatoid arthritis was activation of osteoclast? That's why there was destroying of bone erosions. Here will be osteoblast activation because due to that Rankel system activation, they also start some destruction of the bone structure. But osteoblast think, okay, we should help to bone and start build new bone. And this new bone, they mainly build in lateral part of the spinal column, but sometimes in medial part, and they grow vertically, students. Horizontally like this, yes, but they grow vertically. Like this, for example. And look at here. Due to that, they will be inflamed and fibrosis of the cartilage, spondylitis inflamed, plus new bone growth, they will be finally ankylosing, cavity less, cavity decrease, no cavity, ankylosing spondylitis, start from spondyles, later between bones also happen ankylosis. That's why this disease called ankylosing spondylitis. Target place, spinal column. Tabinda, done?
Yes, ma'am. Yes, ma'am.
Great, okay. I hope other students also understand. Now, due to this, this is called ankylosing spondylitis, and there will be ankylosis of vertebral column and sacral iliac joints, same situation, okay? I explained pathophysiology of how it's changed. Another part, if there will be ankylosis, same situation. It means about sacral iliac joints. Chronic inflamed starting spondyles and fusion of vertebra ankylosis. I explained this 1/10 in previous picture, which I draw for you. And about antibody, we know that there is present antibody because B cells always produce antibody. But when we check RF factor, in this disease, in 90% it will be minus. That's why it's called seronegative spondylitis group disease. If you want to be sure, you can check other antibodies. For example, anti-nuclear antibody, anti-ANA, anti-neutrophil cytoplasmic antibody, which we check also in rheumatoid arthritis, and it will be positive in 30%. Not specific, but might be present. One second. Okay, we come back for this. Look here. HLB27 strongly associated with ankylosing spondylitis. Age between 15 and 35 years old, young age, and more affected women. Oh, sorry, men. 1 second, my child phone. Okay. More specific for men. Now, what they will be in symptoms? They will be chronic inflammation in axial structure, it means sacroiliac joints, anterior chest wall also will be in chronic inflamed, shoulder and hip also will be affected. Large joints more affected in this disease, like oligoarthritis. Start from oligoarthritis, there's rare that it will be polyarthritis. It might be affected 1, maximal 3 joints. Peripheral arthritis, mainly lower limbs, ankle joints. But you know that ankle joints, there will be big ligaments, Achilles tendon, and mainly patients think that there's joint pain. No, usually there will be Achilles tendon inflammation. It's enthesis. I would say about this. And patient come with chronic back pain because there's chronic inflamed. Chronic back pain without with back pain more occurs at night. Second part, of course, there will be sleep problems. Morning stiffness will be, but for differential diagnosis, you should ask time. In rheumatoid arthritis, after 2 or 1 or 2 hours, it's relief after moving of patient. Patient with ankylosing spondylitis tell you that morning stiffness don't relieve. He feels stiffness all the time common. About X-ray, we come back, students, don't worry. Look here, Achilles tendon, enthesitis. Mistakenly, patient comes to you and maybe he say, I feel pain in my joint, but if you will be good doctor, you can palpate this tendon and found that there is enthesitis. Peripheral arthritis, look here, all unilateral, not symmetrical. And as I said, large joints more affected. Hip, knee, ankle, okay, no problem, sometimes ankle. Dactylitis sometimes might be, sometimes not hands, just feet, fingers, rare, but might be. Other extra articular symptoms, it's common symptoms. If you remember in first lecture, I said common symptoms, low-grade fever, lost weight, depression, headache, fatigue, anorexia, okay, this is common symptoms. And one of the specific symptoms extra-articular of patient, it is eye problems, irritation of eyes. There will be keratitis, uveitis. Remember about this. Now, how we diagnose? 1 second, not about this. Okay, don't look here. Just listen. How we diagnose ankylosing spondylitis? As usual, routine test, CBC, urine test, etc. In acute time, we can find ESR high, with that ESR increase, C-reactive protein present, RF factor will be minus, seronegative, ANA may be positive, and imaging test. Now, X-ray. Come back for our X-rays. Look here. No, start from this. syndesmophytes. It is vertical osteophytes, new bone growths. Look here, this is new bone growths, here new bone growths, between vertebra a little bit also present. This is new bone, syndesmophytes here. Due to this also partly start ankylosing. Compare this part. Here also syndesmophytes, no cavity. Here a little bit present, but here decreased cavity already. And later, one second, not this. Yeah, this. Look at here, cavity visible here. Cavity here visible between vertebrae. And there should be cavity, but it's not so visible because there is inflamed, there's fibrosis of the cartilage, syndesmophytes, spondylitis, and also there's syndesmophytes. That's why already ankylosing happened. Later, this part also might be involved in ankylosing, and all vertebra will be look like bamboo tree. That's why patient with ankylosing spondylitis by X-ray this change called bamboo spine. Bamboo spine here and here should be visible normal cavity, but due to that here present ankylosing, we understand that cavity present, but there is connection between vertebrae. Normally, this X-ray should be like this. Look here, there is absolutely free place, but here already syndesmophytes present. Here also present. Students, this X-ray, you understand? Yes, when I show you. Oh no.
Yes, ma'am.
Okay, great, Muslim. I hope you already understand that here should be cavity-free place, but due to connection by syndesmophytes, become to bamboo spine. Look here, no cavity, already bamboo spine here. This is also bamboo spine already. To be sure, again, come back for this X-ray. Look here, there cavity present, but here syndesmophyte already grows. Here also start grows. Here, this part, look here, already this ankylosing happen between these two vertebrae. Okay, this X-ray is so small that I don't discuss. Okay, here in this part, ankylosis happen. Here, we wait, maybe will be. Now, sacroiliitis. Also will be specific change for ankylosing spondylitis, but if you will compare these two, this part free from inflame and ankylosing here, already ankylosis here. Okay, now X-ray, students, X-ray show hard tissue, yeah? We know about this, correct? Or you don't know? You know about this, students? X-ray show hard tissue or not? I need answer from you. I will wait.
Yes, ma'am.
What yes, Mohsin, about what you said yes?
You were saying X-ray shows hard materials, some things like.
Yes, that's why we do X-ray for diagnosis of joint problem disease. And it will be great for ankylosing spondylitis, but for early detection, it's not useful, because if you was attention what I say, early involving of the ankylosing spondylitis change, it is enthesis, soft tissue. That's why by X-ray you can find early change of the ankylosing spondylitis. You will recommend for your patient MRI in early stage, because MRI for soft tissue. Remember about this if some students don't know. Now look at here, and by MRI you can find inflammation of enthesitis will be here. Now, criteria of ankylosing spondylitis students. We have New York criteria, and here will be four criteria. First, low back pain more than 3 months, and it's improved by exercise and not relieved by rest. It means a patient should do motion. But in common, all patients with ankylosing spondylitis in hospital, they always feel pain. If will be trust, they always complain to pain, really. It little bit improve by exercise, this pain. Of course, there will be limitation of lumbar and spinal motion. There will be a sagittal expansion decrease and bilateral sacroiliitis. Bilateral sacroiliitis, second and fourth grade, and if it's unilateral, it should be third and fourth grade. And MRI or X-ray, of course, MRI. If there is already chronic stage with big change, of course, X-ray also informative will be. And look to HLB27 gene, very useful for this disease for test. It's not expensive. You can recommend HLB27. And students, don't confuse when you will found okay, this is extra criteria. It's not matter if you learn by heart this for criteria, it's enough. That's why the next criteria is not matter. They are confused a little bit. Just you should understand that if young patient come to consultation with back pain, ocular manifestation, irritation of eyes, HLB27 positive, it's not always ankylosing spondylitis. It's just proof that here seronegative spondylitis. You should check anamnesis, clinical manifestation, and more deeply ask patient. Because if patient come with same symptoms, but here skin change, like psoriasis, it's psoriatic arthritis. If patient come with this change plus urogenital infection, chlamydia, it is Reiter syndrome. This is differential diagnosis between.
Can you repeat, ma'am?
If patient come with young man, 20 years old, come with back pain, you should check HLB27. It will be positive. ESR selective positive. You don't think that it's ankylosing spondylitis. You should differentiate between other seronegative spondylitis. How you differentiate? If this patient also have skin change like psoriasis, it might be psoriatic arthritis. If this patient also have urogenital infection, chlamydia infection, it will be Reiter syndrome. Reiter. If you exclude all others, you can be sure that it is ankylosing spondylitis. Okay? Because treatment of these different syndromes different. For example, for Reiter syndrome, antibiotic therapy mainly with drug, post-bacterial infection. But you know that sometimes ankylosing spondylitis also activated by the some infection. But it's not necessary to be chlamydia. For Reiter syndrome, chlamydia. Now, after when you diagnose ankylosing spondylitis, how you will treat your patient. Okay, fatigue spinal, it's same what I already said. It is a BASDAI index activity to check disease activity. You will check fatigue, spinal pain, joint pain, enthesis, inflame, and 10-meter test, which called Schobert test, Otta test, Okay, write please students name of this test. In practical part, I will ask you if you will found, it will be great. Schober test, Otta test, O-double-T-O, Otta test, Schober, two tests, enough. These two tests will be proved disease ankylosing spondylitis, and it's look like with Bazdite test. Okay, this all. Now, how you will treat patient with ankylosing spondylitis? As usual, you will recommend non-steroid anti-inflammatory drug, diclofenac, ibuprofen, mucilage, but there is one rule. If in other disease or rheumatological disease, we will give NSAIDs only symptomatical treatment for short time while relieve pain. For patient with ankylosing spondylitis, we will recommend using NSAIDs without stopping long time, because long time using NSAIDs will be prolonged time without ankylosis of spinal column. Understand? Of course, finally there will be ankylosis, but it will be prolonged time without ankylosing of spinal column. Second group, as usual, corticosteroids. About this group and dose, you know, usual dose, usual name. Next group, DMARDs, disease-modifying anti-rheumatic drug. I hope you remember for rheumatoid arthritis, we will recommend methotrexate, drug of choice. For ankylosing spondylitis, we will give drug of choice will be sulfasalazine. In previous first lecture also was sulfasalazine. You can check and you will see that there was sulfasalazine. And for this disease, ankylosing spondylitis will be great biological drugs, named rituximab. Rituximab. Also, name of this drug was in previous lecture. Rituximab. And as usual, I will show a couple of the X-ray and we can finish today. Okay. Now, 1 second, be quiet. Farouk third group and Lip, yes, and Lip Farouk third group. And Lip Farouk, are you here? Okay, and Lip, I will delete the students. Leader of third group, write me on chat after class that you should include Adlib Farouk in list of absent students. Okay?
Okay, ma'am.
Thank you. Okay. Shahrukh second group. Shahrukh. Okay, leader of second group, please. Same, include this name of student in group. Who?
Yes, ma'am, present.
Present. Okay, present. Shahrukh. Shahrukh, please switch on your video, your voice, and explain this X-ray.
Can you hear me, ma'am?
Yeah, you are audible.
क्या है इसका आंसर?
What are you doing, Shahrukh? Shahrukh, please don't waste our time. Shahrukh didn't listen my lecture. Okay. Sajidul Rahman, number 5 group student.
Yes, ma'am.
Please switch on your voice and video.
My camera is not working, ma'am.
Okay, no problem, please.
Yes, ma'am. So there is no space between the intervertebral region, ma'am.
No intervertebral
Sorry, ma'am, can you repeat?
In all intervertebral place or some
Yes, but
part
ma'am,
of
yes, ma'am, this is totally fused, ma'am.
totally.
Yes, ma'am. I got my network connection now, ma'am.
Okay, Rahman, thanks for your opinion. Okay, Shahrukh, please continue.
Yes, ma'am. Ma'am, here we can see, ma'am, lack of intercalated space, ma'am. There is fusion of intercalated disc.
All part spinal column become to fusion.
Yes, ma'am. As per this X-ray, ma'am, there is
Okay, students.
spondylitis.
Okay, ankylosing, not spondylitis.
Yes, ma'am.
Spondylitis
Yes, ma'am.
different.
And closing, yes, ma'am.
Why here's red ring? Because here really ankylosing happened, Rahman. Really here, no, absolutely no cavity, really no cavity. About this intervertebral area, I agree. But look here, this is, sorry, 1 second. Here, cavity visible a little bit, and here, no syndesmal fights. Of course, in this part, ankylosing happen, but not totally, little bit present. Here, already ankylosing, here, little bit present cavity. Here, little bit present, here, ankylosing, Rahman.
Yes, ma'am.
But in this area, total ankylosing spondylitis, yes?
Yes, ma'am.
Yes, there's, I like this X-ray because there's different stages of ankylosing, That's why I like this X-ray. Rahman, Shahrukh, okay. And one X-ray also, which X-ray? Okay. One second. No, not this. Okay, this X-ray, I will ask here, Danish Khan, which group you are? From which group you are, Danish? Danish Khan, are you here or not? Okay, I will delete Danish Khan leader. Which group, Danish?
Fourth group, ma'am.
Write me in list of students who was absent, Danish, okay?
Okay, ma'am.
I will delete the students also. I will ask second group, Sarvish Ahade. Are you here, Sarvish?
Yes, ma'am.
You great, switch on your video and explain this X-ray.
Yes, ma'am.
Do you finish?
What, ma'am? Ma'am, in this X-ray, there is a ankylosing present in the spine. Ma'am, the vertebra, they are also.
Can you say which part of spinal column affected by ankylosing?
Ma'am, the lower part, ma'am.
Lower part. Okay. And
Ma'am, the lumbar region, ma'am. Lower part.
here.
Yes, ma'am.
And this part, thoracal also already. Look here, absolutely no cavity. Sarvish, no cavity here.
Yes, ma'am.
In this part, present cavity a little bit. Here, visible, no syndesmal fights, but spondylitis already happened here.
Yes, ma'am. In the
Yes.
lower part and the uppermost part,
Yeah.
there is no fusion. There is complete fusion.
Okay, and Except is what you found by this X-ray. Students, please, who want to tell except this change, what you found, what you noticed in this X-ray? If you have options, please. Priya Darshini, first group, please.
Yes, ma'am.
Please.
Ma'am, there is formation of syndesmophytes.
Yeah, already syndesmophytes is the reason of bamboo spine, but except is what you found. Students, my dear, look at here. Absolutely no visible small cavity between sacroiliac joints. Sacroiliitis, ankylosing happening. This part little bit present. This part little bit present, but here also ankylosing already happened. Yes.
Yes.
Bilateral sacroiliitis. Bilateral sacroiliitis. It's not about ankylosing spondylitis, students. In normal, I just want to show you. Normally, it should be like this. Look here, smooth one line. Yes, like sorry, like this sacroiliac. On this X-ray, 1 second. Look here, inflame. Yes, not smooth, and not visible in this part. Absolutely ankylosing. Okay, understand lecture, students?
Okay.
Great. Now, leaders, check your group mates, please. Once, 2 minutes for checking. Here, 36 students. Okay. Students, please. Leaders, I'm waiting your message. Please write me. Send me list of students who absent, group number, and list who was absent today. Tomorrow also we have lecture, correct?
Yes, ma'am.
Yes, maybe again we start early, maybe at 2 o'clock if you will be free. Actually, I know you are free, only Nefro lecture and my lecture this week for you. I will write tomorrow again.
Tomorrow we have practice class of physical training.
At what time?
Different groups, different timing. It will start from 8 till 4. Some groups are at 8, some at 10, then 12, 2 and 4.
And how schedule department do this schedule if there will be strange? How you can be in online on lecture?
Sorry, ma'am. It's on Thursday. Tomorrow.
Yes, it's on Thursday. I know.
Sorry,
Elena ma'am, Railroad Hospital, correct?
Yes, ma'am. Right, ma'am. We have Thursday.
Tabinda, because our class also will be at Railroad Hospital in same room. And I know that Elena ma'am once a week go to Railroad Hospital. That's why.
Sorry, ma'am. I was mixing between Thursday
Okay,
and
yes.
Wednesday.
Okay, students. See you tomorrow. Maybe a little bit early. I will inform you. I will check my time. Okay. Maybe at 2, maybe at 1 or 12. I will write early.
Okay, ma'am.
Okay, thank you.
Okay, ma'am.
Leaders, thank you.